Hi, I'm Eddie Atwood, and I'd like to talk to you about cardiology and also my philosophy of medicine. Number one, the first question I have for you is, what is the best thing to happen to medicine? Now, I have people tell me that it's the antibiotics. I have radiologists tell me that it's the MRI. But I want you to know that really the best thing to happen to medicine is you. Because I believe there is no test that can rival your intellectual capacity. And I also want you to have that humble confidence to observe, to pursue history, to question everything, and to be superlative doctors. Now today I get to talk to you about the simpleness of cardiology and the history, because my basic feeling is that you don't have to be smart to be a cardiologist. You just have to do your regular thing, and don't tell my colleagues that I told you this. You can divide cardiology into three basic historical findings. 1, chest pain. 2, heart failure. And 3, arrhythmias. And what I'd like to do is cover those right now. First of all, when I hear about chest pain, or any pain for that matter, it can be, you hear about the OPQRST. I can't handle that. It doesn't go for me that way. So I start first of all with chest pain, and I start thinking about the time question, because the time question is so important, and it has really 3 aspects to it. It has 1, when did you first ever have that chest pain? Because frequently that first time is right then and there in an acute myocardial infarction, but sometimes they have chest pain, for years, and they say, oh yeah, I get this. So I always put that first time. Then the next time is, how frequent do you have this chest discomfort, this chest sensation, so to speak? And then finally is, how long does the pain last, or the sensation or discomfort last now? And are you having it presently? And how long does it usually last whenever you're having it in the past? Then I go to location, and location is fairly straightforward. Is it retrosternal, behind the sternum? Is it on the left side of the chest? Is it underneath the pectoral muscle? And then I ask, where does it radiate? Now, I may have jumped a little bit ahead here, but what I want you to think about is quality. Now, quality, for years I've wondered about quality. The classic finding of pressure, substernal, heavy, elephant sitting on your chest, and all of that. The patients just don't read the textbook. They just do not read the textbook. This is about, I find, sharp. Sharp is the most common question that I hear about. And sharp for me is amorphous. Amorphous is, what does sharp mean? Is that like a knife slicing through or stabbing through? So I try and pursue that question of sharp a little bit further in. But pressure, I've heard pressure, achy, heavy, squeezy. And the most important thing is, they say, doc, it's not a pain, it's a pressure. So you always want to focus on what the patient is telling you. So intensity is a very interesting part to this for me, because intensity only scares me and has relatively no pertinence to the matter. I've had patients come in a full-blown anterior myocardial infarction, and they have no pain at all. It's on a scale of 1 to 10, it's 2. and they're real stoic, and you can see that they're really biting their tongue. And then I've had patients who have non-cardiac pain who say it's a 10 out of 10, the worst pain of their life, and you're going, really? So intensity is important. It gives you some sense and urgency. Then I have what's called B, better, or worse. And this is what makes the discomfort sensation worse, or what makes it better. You're going to hear phrases for better is going to be alleviating, or palliative is another word that you're going to hear. And then for worse, you're going to hear aggravating, and provocative. So there are all sorts of ways to look at the types of pain, but these are the questions that I ask for any pain sensation, and it can be used for headaches, it can be used for abdominal pain, any pain. Now, this is for cardiology only. I call it the 5 P's. And these P's bring me fresh air and I kind of breathing space, because then I said, this is not an acute myocardial infarction. This is something else. So the first question is it palpable? In other words, could this be costochondritis? And so I ask, does it hurt to touch? Then how about if you take a deep breath in, pleuritic? This makes me think of, is it pulmonary? Could this be pulmonary embolism, pleurisy, or some element of that? Then I ask for position, positional. And this positional component is classic pericarditis. Do they feel better when they sit up, worse when they lie down? But it could be anything. It could be a spinal impingement on a nerve fiber when they twist or turn. But it makes me think that this is not coronary artery disease, and that's a relief to me. Then there is prandial, which makes me think more of gastritis or GERD, reflux, esophageal spasm. And then last but not least, there is psychologic. And this one, I never ask the patient, do they feel crazy? But I try and get a good sense of what's going on in their life. Everybody has that sense of life crushing them sometime in their life. And it will happen to you, I hope not very often. And that's how I approach chest pain